Gwen Quinn. Gwendolyn Quinn, PhD, is speaking about reproductive health communication in adolescent young adult patients with cancer. Dr. Quinn is an educational psychologist with her postgraduate fellowship in public health. Dr. Quinn is the Livia Wan, MD, endowed chair and vice chair of research in obstetrics and gynecology, and professor in the departments of population health and medical ethics at NYU School of Medicine. Dr. Quinn studies multiple stakeholder perspectives that affect patient, family, and physician communication. Dr. Quinn's research and teaching work encompasses reproductive health, sexuality, and fertility preservation in pediatric, adolescent, young adult, and LGBTQ populations affected with cancer. Dr. Quinn.
Thank you. Good morning, everyone. Let's see. Green button. Okay. So how many people were aware that adolescents and young adults diagnosed with cancer were considered a group suffering from health disparities? So a few. Okay. So that's good. So early on when we were starting doing this work in the early 2000s, there was a lot of epidemiologists who said, oh, 70,000 a year, that's less than 2 or 3% of all the people who get cancer. This is an orphan group. But due to a variety of circumstances, because if a woman in her 20s now expresses that she's having pain in her breasts, she's not just dismissed as, it being related to hormonal cycles. She's actually being evaluated for breast cancer. And so these cancers are being detected more often in the adolescent and young adult population. So when we talk about adolescents and young adults, or AYA, we characterize them typically in the United States as ages 15 through 39. Now, there are a variety of age ranges, and it depends whether you're in Europe or which country that you're in, but basically it's based on people in their reproductive age. And I'll talk more about why that's important and what this looks like. But in addition to them being of prime reproductive age, they have unique psychosocial and medical needs. Also in this group are people who had cancer as a child and now are a survivor of that pediatric cancer, suffering from late effects or the after effects of cancer that they had. So, for example, premature ovarian insufficiency or early menopause. So in some cases, some drugs being used, a young woman who receives chemotherapy can possibly enter into menopause 5 years after the end of treatment. So imagine that you're 15 when you have treatment, and now you're 20. And as one survivor told us, she was the only person she knew in her community who was going through menopause at the same time as her mother. So this 20-year-old now going through menopause has to look forward to the bone density and cardiac issues when she's in her 40s that women would not really be thinking about till they're in their 70s and 80s if they're lucky. There's also social and financial toxicity. If you're 23, for example, and you're diagnosed with cancer, in most cases you'd be out of your parents' home, you might be living on your own, you've been working in your job, but maybe not for too long, or a year or two, maybe you're still pursuing higher education. Now you're diagnosed with cancer and you become a child again. You go back to your parents' home for care. You might fall back on their insurance, and you probably don't have a lot of stability within your employment for time off for this cancer care treatment. And so in addition to your student loans that you might have already acquired, you have a lot of hospital bills. So those are some of the reasons why this group is particularly unique. I'm going to focus more on the reproductive health issues, and I'll come back to this slide when we talk about policies, but all of these organizations and probably others, the American Society of Clinical Oncology, the National Comprehensive Cancer Network, the American Academy of Pediatrics, they all have guidelines that say that conveying information about reproductive health is best practices for AYA. But it's not always the case, and a lot of institutions or places providing care are not equipped to offer this counsel or these referrals. So the World Health Organization definition of reproductive health expands beyond fertility. It includes sexuality, use of contraception, and sexual well-being. We like to think of reproductive health as consisting of romantic partnerships, friendships, body image, sexuality, sexual identity and orientation, contraception, and psychosocial adjustment. And these things are all very interrelated, and we talk a lot about fertility and potential infertility, and while that's not necessarily the most important thing, we found that a lot of decision making with regard to all of these other things can be built upon fertility. And not even so much in terms of, will I be able to have a genetic child in the future, but just what it means to potentially be an infertile person. So young women, for example, will say, I hate my body, I hate how it looks, whether they have cancer or not. But particularly people who are going through cancer treatment, they will think, in addition to not being able to have a child in the future, and these scars that I have and this bald head that I have, who will ever love me? How will I ever find a partner? So I'll make my life changes and life choices based upon the fact that I'll probably be a single person. We also include that beyond the guidelines suggested by those organizations that I showed that primarily focus on oncologists and the responsibility of oncologists, because of a training program that I have that I'll talk about in the end, we think that a lot of this responsibility is probably better suited for the allied health professional, which we include to be nurses, social workers, psychologists, and physician assistants. So the primary reason that we learned when we did a national study of oncologists about why they don't talk about reproductive health or infertility with their patients is, I don't have time and I wasn't trained to do this. But they're very happy to turn this training over to another member of their team, and most of the time team members are happy to accept that, but want to be empowered by the clinician to be the one to have these conversations. So some of the challenges in communicating about reproductive health issues are, of course, the various developmental stages. So the way you would talk about potential loss of fertility and sexual function to a 15-year-old who may never have had a sexual experience would be very different than you would talk to a 35-year-old who's been in, a partnered relationship for a long period of time. And so it can be very challenging to figure out what words to use and what examples to use and how to lessen the potential embarrassment as you're talking to people about this at different stages in their life. And as I mentioned, time and the resources of the institution. So one of the things that I think is, I don't know the right even adjective to use for this, disturbing, I guess I'll say, is that fertility preservation, or offering someone the opportunity to preserve their fertility prior to cancer treatment, is the one standard of care, best practices, that is not covered by insurance. Now, some things are changing legislatively. Some states are one by one, creating new legislation that does have this covered. But it also brings about the point of why it is so challenging, and understandably so, for a physician to talk about this, or a nurse, or anyone. Because if you are dealing with a person who, as we did a series of interviews with physicians in Detroit, who said, I've had to find shoes for my patients to go home in. I've had to find a coat for them to go home in. Why am I going to tell them about fertility preservation, which for women can be in the tens to $20,000s of dollars, when this is something that they can't afford? So that's understandable that serves as a barrier. Or if you happen to live in Wyoming, and I'm not sure if that's the right state, but there's at least 2 states in the United States where there are no reproductive endocrinologists. So imagine telling someone you should consider fertility preservation because you have a high likelihood of being sterile after this treatment, but you need to leave the state to go find that care. And oh, by the way, your chemo needs to start in 72 hours. So the other thing that's very an interesting concept in this is that we are more and more now seeing that patients are being talked to about potential loss of fertility as part of their reproductive health. And that message is oversold. So we have not an insignificant number of people who, both when I was at Moffitt and now that I'm at NYU, becoming pregnant during their cancer treatment because they believed that they could not get pregnant. So that's why the discussion of contraception and how that contraception may need to vary, whether you're on treatment or off treatment, or who your partner is. And as I said before, this impact of fertility, of even among people who've never thought about if they want to have a child or not, when they suddenly find out that they can't, they really think it's going to impact their romantic partnerships in the future. And finally, I guess on this point is that while there are some patient education materials, they are very heteronormative. They are aimed at the straight, white couple in a relationship. And so this is not just in the case of reproductive health, but I was talking with, I did a focus group with women who are in same-sex relationships with women after breast cancer, and this one woman said to me, you know, my physician handed me a brochure that said reclaiming your sexuality, or resuming your sex life after cancer. She said, on the picture was a cover of a white man and a white woman, and I'm a Hispanic woman in a relationship with another woman, so I just put that in the trash on my way out because I figured that that's not for me. So right now we don't have a lot of communication with patients that are really aimed at the broad range of lesbian, gay, bisexual, and transgender patients who are getting cancer and kind of creating their own networks that tend to be outside of cancer centers or institutions offering cancer care. Oops. So some of the health literacy issues that are involved with this population are really a lot of this language. So to my knowledge to date, no one has successfully sued their provider for saying that they did not receive this information. But there have been several people who have tried, who have said, you did not adequately explain to me that I would be infertile as a result of cancer treatment and that there were options for me to preserve fertility. So the one case that I was able to get access to that was settled out of court, they asked the patient, they said, what did you think when you signed this consent form for chemo that said you would be sterile as a result of receiving cancer treatment? And the patient said, I thought it meant I would be very clean. So a lot of the terminology that we use that we're talking about this is not necessarily understandable to a lot of patients. As difficult as may sound when you're trying to explain to young men what is required to do fertility preservation, that they need to masturbate, a lot of them are not familiar with that term. And for women, explaining egg retrieval and ovarian stimulation, that ovarian stimulation and the transvaginal ultrasound that's needed for the egg retrieval. Many of them are concerned that means that they won't be a virgin anymore, and so they're not interested in that either. So there's a lot of languaging issues surrounding that. And then, as several of our speakers have noted today, many people just hear the word cancer and that's all they hear. I need to take care of this cancer and I'll worry about whether or not I can have children or find a partner in the future. I'm going to skip over some of these things because I see my yellow light coming on, but if I could move this, I would move that reality check down because it would say preserving sperm or embryos or oocytes does not guarantee a baby to take home, which is another way that we have communication problems. So some people think, all right, well, I've banked this sperm, I'm good, I'll definitely be able to have children in the future. And only 50% of people who use assisted reproductive technology are successful. And that can be even less so depending upon the type of cancer that you had and the age that you were when you preserved. We also have communication issues. In 2006, when ASCO first came out with guidelines, our acknowledgement was to say to people, it doesn't matter what you do with the fertility that you preserve, you can worry about it later. And now we know that's very poor advice, that women and couples are very conflicted over what to do with surplus embryos or surplus eggs that are not used. The other common refrain that we hear from people when we talk about fertility is, oh, well, I'll just adopt as adoption isn't easy for anyone, regardless of your cancer, if you've had cancer. But if you have had cancer, it's exceptionally difficult. You often need a letter from your physician saying that you've been cancer-free for 5 years, that you've never had a recurrence. And if you start this process when you're 33, and then by the time you're 40, you're no longer age eligible for a newborn. Those are important things. The other thing that I think is really important to talk about is, even though a lot of us know that less than 10% of cancers are hereditary, almost 100% of AYA assume their cancer is hereditary. And so a lot of them turn into what we call silent sufferers. They will not tell you, they'll say, I'm not interested in fertility preservation, I don't care about this, because in their mind what they're thinking is, I'm not going to have a child and pass this cancer along. So it can be very important to preemptively let patients know, in case you were worried about it, there is no hereditary component to this. Or I will send you for genetic counseling and you can learn about if there is a hereditary component. And also talking about pre-implantation genetic testing as being an option for people. Although several studies that we've done with healthcare providers, they don't agree with it. They don't think it's right. And it's an interesting dilemma about whether or not you should have to refer or discuss for someone for a procedure that you don't agree with. So getting to policy and guidelines. As I mentioned, there are multiple guidelines that exist from entities about what should be discussed with patients and how it should be discussed. But I think the key is readiness, institutional readiness, and policies within an institution. So I have a detailed slide here, but I'll just kind of break it down and move on to another one that's more explanatory. There are a variety of things that should be discussed at diagnosis and at active treatment, and again at survivorship. And being ready to do those things takes an examination of the institutional readiness. So several things that I would recommend is that identifying if within your institution you have a way to refer people to reproductive specialists and mental health professionals. If you have a system to document this. As I noted earlier, there have been no successful cases, and that was always because there was documentation in the chart that a conversation had had. And we know that many patients don't remember conversations that would have been had, so documenting it is kind of a legal protection. As has been said many times today, communication training for providers on not just to talk about this, but how to talk about this in sensitive ways. Support for patients as they're pursuing these services. And patient education aids and tools that are aimed at this population that are relevant across the gender identity and sexual orientation spectrum. Just very briefly, I'll mention that if you're interested in training, I have some flyers I can give. We have a training program funded by NCI, no charge to the trainees, 17 CMEs, that trains these allied health professionals to communicate about reproductive health issues with these adolescents and young adult patients. Thank you.